Welcome to this Institute for Research on Public Policy webinar on federalism and long-term care. This webinar is the second in a series of events about long-term care. The webinar will start shortly. In the meantime, here are some important instructions. A moderated Q&A will follow the panel discussion. If you have questions, we invite you to ask them using the QA module located at the bottom of your screen. Please note that beside our best efforts, we will not be able to answer every question. Please keep your questions short and to the point, and we will try to answer as many as possible. The webinar will be recorded, and a link to the recording and the presentations will be sent to you. After the event, please take a few minutes to respond to our short survey. A link to it will be shared in the chat. If you have any additional comments or questions following the webinar, please send them to us at communication@irpp.org. And I'll leave you with the moderator of today's event and research associate at the IRPP, Paisley Sim.
Thank you, Ricardo, and thanks for joining us today. I'm Paisley Sim, research associate at the IRPP, and I would like to begin by acknowledging that I'm broadcasting to you from the unceded Indigenous lands of the Kanien'kehá:ka Nation, Tiohtià:ke, Montreal, which is historically known as a gathering place for many First Nations. This webinar explores the role of federalism in the Canadian long-term care system. In the first two waves of the COVID-19 pandemic, more than 2/3 of Canadian deaths occurred in long-term care facilities. This experience is a clarion call. If we do not act now, the failings exposed by the pandemic will continue to take their toll on the lives of Canada's most vulnerable citizens. We have a panel of experts today exploring this issue. Carolyn Tuohy is Professor Emeritus at the Munk School of Global Affairs and Public Policy at the University of Toronto. Danielle Béland is the Director of the McGill Institute for the Study of Canada and James McGill Professor at the Department of Political Science at McGill. And Michel Grignon is the Graduate Chair of the Department of Health, Aging and Society at McMaster University. Welcome, everyone. Before I turn it over to the panel, I want to let everyone know tuning into this webinar that you should ask questions, and the Q&A box provided at the bottom of your screen will be used for that. At the end of the presentations, we're going to try and answer as many questions as possible, but please note that despite our best efforts, we will not get to all of them, given the very large number of participants today. This webinar will be recorded, and the recording, along with the presentations, will be sent to everyone after we wrap up. And now I'm going to turn it over to Carolyn Tuohy.
Thank you very much, Paisley. It is a real pleasure to be here and to have the opportunity to share my thoughts about this very important policy matter with all of you. I'm going to share my screen. And there. I want to start with a bit of context. Sadly, this context is all too familiar, and we heard quite a bit about it last week. So I won't spend a lot of time, but I want to give you perhaps a slightly different way of looking at our experience with COVID in long-term care facilities in Canada. If you consider deaths per 100,000 in the non-home care, the non-long-term care population, non-resident population, and deaths per 100 among long-term care residents, you can see that across countries, there's a very strong relationship. And that's not surprising. Community spread had a lot to do with the experience of residents in long-term care facilities. And Canada is right on the line, and I've put boxes around the federal systems here, so you can see that federalism itself doesn't seem to have made a lot of difference. Canada's pretty much on the line, what would be expected, and it's actually toward the origin of this graph. There are nations who experienced much worse conditions than we did. But the fact is that there are more elderly Canadians in long-term care facilities proportionately than in many of these other countries. And what that meant was, as a share of our deaths, as Paisley pointed out at the beginning, we had a very large share of our deaths occurring in long-term care facilities over the 3 waves of the pandemic. These are actually the first 2 waves that are captured here. The 3rd wave was somewhat better, largely as a result of the rollout of vaccines. There was also considerable variation across provinces. This was a study published in the CMAJ in September, showing the difference in infection rates and mortality rates in Ontario and BC long-term care homes, about 4 times in Ontario, relatively speaking, what they were in BC. And this, of course, did not go unnoticed by the Canadian population. This truly galvanized public attention, not only to the dire experience itself, but to the variation across provinces. I thought I would take a look at media coverage of long-term care compared with another of the so-called stepchildren of Canadian healthcare that are outside the Canada Health Act umbrella, and that is pharmacare. And here's a graph that shows the number of articles mentioning either long-term care together with government or pharmacare or universal drug insurance from 2010 through to September of 2020. And I have actually never produced a graph like this in my career. It is so striking, that hockey stick at the end showing the increase in attention to long-term care issues. So this is what political scientists would call a focusing event. So what are the challenges here? They're twofold: fiscal and regulatory. In the first place, the fiscal challenge. The conference, Robin Gibbard for the conference board in 2017, at that point estimated a need for an additional almost 200,000 long-term care beds by 2035, taking into account demographic change and currently unmet need, as well as current utilization patterns. And he calculated that that would require $64 billion in additional capital spending to construct the facilities, and annual operating spending, additional annual operating spending of $14.4 billion by 2035. McDonald, Wolfson, and Herdes for the National Institute for Aging used a different methodology, the life path simulation, very sophisticated life path simulation model, and estimated out to 2050 that the cost of public care in nursing homes and private homes, so facility care and home care, would roughly double relative to the macro economy by 2050. And that didn't even take account of the number of unpaid hours of care offered inside the home. And keep in mind that these estimates assume current patterns of utilization, which we know involve chronic staff shortages and insufficient hours of care. Now, we are currently funding home long-term care publicly, comparable to other OECD nations. We're in about the top third. Now, those of you who were on the webinar last week will wonder about this graph, because Dr. Sinha showed us a somewhat different comparison. His data included countries that report both health costs and social care costs for long-term care. Unfortunately, not all countries do that. Canada doesn't do that. So this is a graph that is just apples to apples comparison of long-term care spending as reported under the health category, and Canada is in the top third. But we need more. We need it more as leverage on reform, and we need more to meet the demands that I outlined in the previous slide. The regulatory challenge is one of insufficient quality control. What may not be fully appreciated is how concentrated these problems were in a smaller segment of homes. In Ontario, for example, 90% of the deaths in nursing homes occurred in 15% of the facilities by mid-November 2020. And these were not entirely, but largely the grandfathered facilities with outdated designs, particularly multi-bedded rooms and shared bathrooms. There's also insufficient enforcement, varies a good deal across provinces. Some provinces like Ontario really focus on a tight regulation of budgets, of what you can spend on, but a looser enforcement of staffing requirements. And accreditation can pick up some of the slack here, but it is voluntary, although provinces like Ontario offer a premium on their per diem support to the home if it is accredited. But there is some evidence that accreditation has limited effectiveness. One study, for example, showed that accredited homes were less likely to have falls amongst residents, but there was really no difference on other things like infection and pressure sores. Now, my point here is that to address both the fiscal and the regulatory challenge, we need to exploit some unrealized opportunities that Canadian federalism offers. A Canada-wide risk pool, a potential for large-scale data collection and analysis across the country, the diffusion of best practice, all the while allowing delivery to be tailored to local circumstances and preferences. These are the classic advantages of federalism. It's been suggested, therefore, that we should extend the Canada Health Act model to long-term care. There are several problems with that model, however. One of the least of the problems, although still an issue, is that we would need to allow for private charges for long-term care, given how intimately long-term care is entangled with lifestyle implications, and preferences may well vary in that regard. But more importantly, there is no counterpart in long-term care to the medical profession, an empowered body of professionals with a common base of knowledge that really are what guarantee or enforce common standards across the provinces. There's no counterpart to the medical profession in long-term care in that regard. And furthermore, if we simply roll long-term care into the Canada Health Act, our experience over time is that it is likely to lose in budgetary competition with acute care, with physicians and hospitals. So, what is an alternative approach? I argue in my paper for IRPP that we need to take advantage of areas of concurrent jurisdiction. Rather than having the federal government transferring funds conditionally and essentially pushing on a string, let's reach for areas in which there are really opportunities for truly joint decision-making and joint ownership of programs. I focus in the paper on immigration as well as the pension area, but here I'm just going to focus on the proposal for long-term care insurance as a supplemental retirement benefit alongside the CPP, QPP. And I argue that that model is better suited to long-term care than the Canada Health Act model is, given how concentrated the consumption of long-term care is in the older years of life, even more so than overall healthcare consumption. So like the CPP, QPP, this long-term care insurance benefit would be funded through employer, employee, and employee contributions over the working life of an individual. It would have to be supplemented from general revenue, at least as the fund was building up, and perhaps on an ongoing basis. Both Japan and South Korea have a mix of general revenue and insurance contributions in their long-term care insurance plans, for example. And we would need a similar benefit for those who receive OAS and GIS and not CPP because of their work history. How would this be administered? It would be administered comparable, in one sense, comparable to the CPP and QPP, in that it would be administered by, the transfer would be administered by the federal government. The agency would be accountable to Parliament and to provincial ministers, as is the case for the CPP. The QPP would be administered by Quebec, and the LTCI benefit would as well. The benefit would be paid, now this is a difference from the pension model, as a flat cash transfer based on the level of need for care, not on the level of your contributions. And that need for care, your eligibility would be assessed through existing provincial mechanisms. You could assign, and this is another difference from the CPP, you could assign the benefit, however, to a qualifying provider of either institutional or home care. And those qualifying providers would have to be approved under the plan, which would provide a mechanism for developing and enforcing national standards on the basis of joint decision-making between federal and provincial governments, not unilaterally decided by one level or one order or the other. And I suggest that, for example, there might be a long-term care insurance council, I've just made up that term, but an arm's length agency that would be appointed similar to the investment board for the pension plan, that is to say, appointed by the federal minister, but from a list of provincial nominees. And enforcement would remain with the provinces. The advantages of this model are that it provides a dedicated source of revenue, unlike simply relying on periodic negotiations over transfers of general revenue. It is by its nature geared to demographic change over the, particularly as the plan matures. It provides a mechanism of cross-provincial harmonization, as I mentioned, through the designation of qualified providers, and those decisions would be made through a joint process. It would generate administrative data to provide the basis for informing that standard setting. And over time, it could provide a common platform of funding for a range of long-term care services and facilities, as opposed to the current silos in which we fund institutional care, home care, and indeed private retirement residences. There are models in Germany, Japan, and the Netherlands, and Korea and other countries that we can learn from. We can't transplant them directly, but we can certainly learn from their experience over time. There are, however, devils in the details of design. One of the principal design issues would be how to integrate this long-term care benefit with existing provincial programs and funding. We do not want the provinces to be substituting this benefit for funding that they're already providing. As noted earlier, we need more revenue in this space. So one option would be to establish additional per diems at the provincial level that would be essentially equal to the long-term care insurance benefit, again, depending on the level of need, and could be assigned to the provider accordingly. That would allow for increases in quality and through design, some reallocation to provide for the expansion of the number of places. There are also issues of taxation. Should the contribution be eligible for a tax credit or deduction? Should benefits be taxable? I do not go into this in the paper, and these are clearly issues that would need to be considered over time. They would have a lot to do with how progressive the plan would be. The federal budget, the recent federal budget, sadly, I think was a missed opportunity for long-term care. It provided $3 billion over 5 years, in addition to the $10 billion over 3 years that had been provided in the fall economic statement. The federal government signaled its intent to work with the provinces toward national standards, but didn't provide any real mechanism. And it augmented the OAS by a one-time payment of $500 in August 2021, and then as of June of next year, an ongoing 10% increase. That could have been, I think, much better constructed as a benefit specifically for long-term care. However, the federal budget is not the last word, and it is quite possible that there could be follow-up within the parameters established in the budget, even before next year's budget. Presenting long-term care is essentially a bookend to the child care commitment of the federal government, dealing with care at both ends of the life cycle. Treating that $3 billion as a down payment with the promise of more to come. It may be too late to direct it at this point to infrastructure, to upgrade and replace outdated facilities. I hope it would not be too late, but in any event, that is the key pressing need for infrastructure. And most importantly, an announcement of a process toward a national strategy. Perhaps a royal commission. The Australian Commonwealth government, which has sole jurisdiction over what they call aged care, has just, there has just been a report, a long anticipated and I think quite influential report of a royal commission on aged care in Australia. If there were to be such a commission, it should again be appointed by the federal government from a list provided by both federal and by a federal provincial nominating committee. And it should be a policy development commission. It should not be looking once again at what the problems are. We know what the problems are. What is the state of the art that we have in place now about potential policy solutions? And a commission could well consider and recommend among those policy solutions. So if you want more on this, my study for IRPP is listed here, but most particularly now I look forward to exchanging with my colleagues and to your comments and thoughts as we wrap up. Thank you very much.
Thanks very much, Carolyn.
I shall stop sharing my screen now and let others in. Good.
Thanks very much. And we're now going to turn it over to Danielle Béland.
Thank you very much. Good afternoon, everyone. Thank you so much, Carolyn, for your presentation and your paper, because I think it's extremely timely, and it's something that I think is really helping to shape the policy agenda on long-term care. And as you showed very clearly, this is something top of the agenda right now in Canada, and I think that your work is really a great contribution to that debate, original contribution. And so I'm really happy that I can comment on this today. Now I will comment from, I know Carolyn is a world-renowned specialist of comparative healthcare, and she has published a lot on comparative healthcare. I've published a bit on healthcare, but a lot of my work is about fiscal federalism and also about pension reform. And because the starting point of Carolyn's model is actually the Canada and Quebec pension plans, programs I've written extensively about, I will focus my discussion on the politics of using that model in the context of Canadian federalism. And I know that Michel will concentrate more on economic and demographic issues, I will talk more about politics because, well, I'm a professor in the Department of Political Science, so that's what I do for a living. So let's put up the slides here, very short presentation, obviously. Here summarize in relationship. So a key aspect of the paper is the idea that CPP and QPP constitute a ready-made model for long-term care insurance in Canada. And so according to Carolyn, and that's quite clear. So on page 16 of the text, this CPP-like long-term care insurance could be designed to be self-sustaining so that contribution rates can be adjusted according to actuarial projections unless federal and provincial governments agree to intervene. And so what's important here from a political standpoint is that this approach is really about joint decision federalism. It's a concept that we associate with the work of Keith Banting, who has used it extensively. And the idea of joint decision federalism is about the fact that subnational units, in this case provinces, have a collective veto point over not only the adoption, but the reform of, in this case, national long-term care insurance. But I frame that as a question because I'm not exactly sure of that, and I would like to know if Carolyn actually thinks that the provinces will have a similar veto point as in CPP, which is that in order to reform CPP, you need support of at least 2/3 of the provinces representing at least 2/3 of the Canadian population. So the bar is quite high to reform CPP. And I'm wondering whether this bar will be exactly the same in the case of LTCI, so the long-term care insurance that Carolyn has in mind. Now, there is something a bit paradoxical, I think, about using CPP and QPP as a model, of course. It's because we are not talking about one national program here, but two programs. One that is only for one province, Quebec, QPP, and one that is for the rest of the country. And it seems that based on her presentation, Carolyn thinks that Quebec will opt out of her long-term care insurance proposal and will create its own provincial proposal. The question, though, is I'm wondering, considering the current political context, whether other provinces might not be tempted to opt out of that approach as well. I'm thinking here, obviously, about Alberta. The demographics in Alberta are quite different than the demographics in other parts of the country, something that Michel will talk about later in his presentation. And right now, there is a discussion in Alberta about opting out of CPP itself, something that was proposed by the Fair Deal panel that issued a report last spring in Alberta, a report commissioned by Jason Kenney. So what constitutes a national program here? If we are talking about two major provinces, two of the four largest provinces opting out of it, which would be very likely, I think. And then would Ontario want to be part of this under Doug Ford? Again, partisanship is a key issue. And I want to talk about this, the current political map in the provinces and in relationship to what's happening in Ottawa and what proposal we have at hand here. So let's talk about the political feasibility of a quote unquote national long-term care insurance program in the current political and electoral environment. So many of the provinces are under right of center governments that might not be so keen to have a new social insurance program in Canada that will impose new payroll contributions. When we go back to the development of the Canada Pension Plan and its history, the creation and the expansion of the program, the expansion that we witness only, that is actually taking place right now. We are currently increasing payroll contributions for CPP. That became possible in 2016 only because the provincial partisan map aligned with the Liberals in power, and they were able, for example, in Alberta, you had Rachel Notley in power. And that makes a difference, very different political animal than Jason Kenney and the United Conservative Party. So expansion of CCP, and I wrote about that with Kent Weaver, became possible in part because of the provincial map and the federal map as well. They aligned. The Liberals form a majority government after in the aftermath of the 2015 federal elections, and the map, in Alberta also changed that year in 2015. And overall, it was quite favorable for the Liberals in terms of the partners that they had in the provinces to come up with an agreement that most provinces would support. Because don't forget, to reform the CPP, you need 2/3 of the provinces representing at least 2/3 of the population to actually get things done. And so that's an important factor here. Right now, I don't think that the stars will be aligned. Let's say if the Liberal government will put forward such a proposal, there will be a lot of resistance from a number of provinces, even probably beyond Quebec and Alberta. And I think that's something that that needs to be acknowledged. Now, when we talk about federalism, yes, it's the strength, but it's also a weakness in some ways, and we have to understand both sides of the equation here. I understand why Carolyn is proposing to start with a commission, perhaps because the stars are not aligned politically at the provincial level, at least, to actually launch negotiations with between Ottawa, the provinces and the territories on the creation of such a joint decision long-term care insurance program modeled on CPP. So I think a commission is certainly a way to let political time flow, and hopefully maybe the political map, hopefully for this proposal, the political map in the provinces will change over time. I don't expect much change in Quebec though. For the time being, Legault is very strong. So I think we could assume that Quebec will opt out of such a program, even if there were fiscal incentives to participate for political reasons. So I think that the road ahead in terms of negotiations between Ottawa and the provinces that were necessary to create CPP in the first place, and later to reform it in the mid-late 1990s, and later expand it in start with the agreement of 2016. I think it takes really a lot of efforts, and it can work. We saw it with CPP, but often it's a road to nowhere. And there were quite a few, several attempts, failed attempts, to expand or reform CPP in the past, like the so-called Great Pension debate of the early 1980s. And when the stars didn't align in terms of partisanship and other factors, it fell apart because it's joint decision making. So you cannot just, you need several partners to dance here. And so it is quite risky business politically to start negotiations with the provinces over this. So the political obstacles to the creation of the program that Carolyn has in mind are strong right now. But I'm not saying that it's not possible for such a project to, at some point in the future, gain political traction. But you will need probably a different partisan map in the provinces, more left-leaning provincial governments, maybe more NDP governments, or Liberal governments. In the case of Ontario, could be NDP or Liberal. But right now, I think it's a long shot. So that's my comments. And now I think it's Michel's turn. We'll focus on a different set of issues. Thank you.
Thanks very much, Danielle. And we're going to pass it on to Michel Grignon.
Okay. Thank you very much. Can I share my screen, or do I need to wait for? Yeah, okay, thank you. So let me share. Here it is. Okay, let me hope. Do you still see it? No, okay, I need to resume share, okay. Sorry about that. Okay, I hope it's working now.
Yep.
Okay, thank you very much. And let me start from the beginning, that would be better. Okay, sorry about those technical issues. So I'm also very honored and happy to discuss this, what I consider a brilliant paper. I'm all in favor of some kind of an insurance plan. And I think a national insurance plan would make total sense. I fully understand what Danielle just said about the difficulties, the political difficulties, and I will have one piece of discussion on that. So let me start right away with how I wanted to discuss Carolyn's proposal, which again I think is brilliant. So I have three, I would not maybe supplementary arguments. It's maybe a better way to say that is my economist way of saying the exact same thing as Carolyn. But that why I support such a national plan. I think a national plan would be more equitable. I think a plan would be welcome because it would have explicit standards. And I think also that a long-term care plan would have the great merit of putting together what we do in facilities and what we do in the community. I would like also to raise two issues. The first one is, I think, very similar to what Danielle was alluding to, the fact that it might be very hard to put all the provinces in the same bed, if you forgive that kind of strange metaphor, and because there might be strong differences in preferences across those across provincial values. And the second, my second issue is more about the redistribution aspect across income levels of such a plan. So let me start with the reason why I think a plan, a national plan would make total sense. So the thing is that, well, Canada is a federation, and it's a federation in which we can move freely. Labor and capital can move freely, and labor maybe even more so than capital. And as a result of that, well, we know that very well. The young folks in Nova Scotia go to work in Alberta, and then they come back when they're older and they need potentially long-term care. As a result of that, the share of population of Nova Scotia who is 70 years old and older is about 15%, whereas it's only 9% in Alberta. And if we go to the 80 and older, then the shares become almost 5% in Nova Scotia versus 3%, a bit more than 3% in Alberta. So obviously today, if provinces are left to their own devices to support long-term care, well, it's going to be totally unfair. And I mean, it's not a small difference, it's a huge difference. And there's no, I would say that if we have some kind of equalization payment between the haves and the have-nots, then here, obviously, we should have some kind of compensation mechanism. And a national plan would be a good way to do that. Otherwise, we need to be ready to support the idea that the elderly dependent are poorly treated in Nova Scotia, or that the taxpayers in that province are unfairly treated relative to those in Alberta. So of course, we could imagine that if, let's say, the elderly were smart, they would move to Alberta, where obviously there is more fiscal room to support them, but we know that's not the way it works. The second reason why I think a plan would be welcome is by virtue of having a plan. So if you have an insurance product, and that's the plan that Carolyn is suggesting, an insurance plan, what it creates is a right to something. So there is a quid pro quo that is exactly what we have in the CPP. When I pay my contributions to the CPP, I expect to receive something in exchange for my contribution. The support for long-term care through general revenue is not a right. It's more like a commitment in the future from the government, from the province, but a commitment that is, of course, conditional on having enough money simply in the general revenue, having enough money in the province coffers. So to that, I would welcome an insurance product, an insurance plan. I think also that, and Carolyn alluded to that, earmarking makes it much easier to sell to taxpayers. Taxpayers may not be willing to pay more taxes for to increase the general revenue as a whole, but they might be willing to set some money aside in a public plan to pay for their long-term care when they need it, if they know the money is going to be used for that. And a very important thing also is that it would create, and Carolyn also mentioned that, it would create a body that would, an institution that would assess the need of individuals, and that would be separated from the provision of services. Today, in most provinces, in Ontario at least, the facilities that provide care are also the ones who assess the need of the residents, which is an obvious conflict of interest. So having a plan would, the way it works in Germany, France, Japan, would allow us to separate those two crucial activities in the provision of long-term care. And the last thing that I think is possibly the best advantage of having a plan would mean that for once in Canada, we would be thinking of long-term care as a whole, including facilities and home care. I think, as Carolyn mentioned, we in Canada, we have a demand issue. So we have more, the percentage of the population 80 and older with in a long-term care facilities is higher than in the average of the OECD, and quite substantially, 12.3% versus less than 10%. That's a big difference in terms of how much resources we have to commit to long-term care. Interestingly enough, I tried to do the same thing for home care. Well, Canada does not even report on the recipients of home care by age or overall. We don't know how many recipients of home care we have, or we are not, we don't trust our data enough to send them to the OECD. So that tells you how home care, so the long-term care provided in the community, is a blind spot in long-term care policy in Canada. Another statistic that I find interesting is that 63% of residents of facilities have dementia. Very often we present that as, oh, this is a very high proportion. I would say it's a low proportion. I think that the goal of a well-functioning long-term care system would be to have anybody who doesn't suffer from dementia being living in a community, and facilities being really reserved only for people who suffer from dementia. So what I'm seeing here in that statistic is what happens to the 37% who don't have dementia? Why are they in a long-term care home, a facility? They should be at home. So having a plan would force us to think as long-term care provision as a whole, and possibly, I think, if we have some secure funding for home care, we would have fewer people in our facilities that would make, that would cost less money, and that, I think, improve the well-being of individuals. Now, my two, let's say, smaller issues with the plan are, the first one is the feasibility issue. And so here, I'm using the same study that Carolyn mentioned, the study by Liu and et al., that compares Ontario and British Columbia on the very recent case of COVID-19. So COVID-19 has shed a light, a very cruel light on what happened, what was happening in facilities, but it also shed a light on the major differences between across provinces. So if we look at, so BC did much better during the first wave than Ontario in terms of mortality. The mortality, and here what I would like to do is to decompose the mortality per bed. So how many residents of long-term care facilities died relative to the number of residents, which is M over B, and we can decompose that as M over I, which is the number of deaths relative to the number of infected. So that's the case fatality, times the number of infected relative to the number of outbreaks. So that's how well outbreaks are controlled, times the number of outbreaks relative to the number of residences or facilities, and divided by the size, the average size of facilities. So what we can see here is that through the paper is that BC did much better in preventing outbreaks and managing the outbreaks once they took place, despite having more facilities, which means despite here having a B over R that is smaller. So they really did very well on I over O and O over R. How did they do that? First of all, they pay slightly better. So their operating costs are slightly higher than in Ontario. And maybe the cost of labor is slightly lower because they get substantially more hours of care per resident than Ontario by paying slightly more. But the bulk of the difference between the two provinces is the fact that 3/4 of BC residents live in private rooms versus only 1/3 of Ontario residents only. This is what Carolyn referred to as the grandfathered institution. So those facilities that are substandards but are tolerated in Ontario, but not in BC. So obviously BC has a much higher standard in terms of quality. BC has invested much more in its facilities than Ontario has. Well, now we could say it's simply an oversight. Ontario didn't do it on purpose. I have a hard time believing that. When you underinvest over the course of 40 years, it may say something about your values. It may be the fact that Ontarians are cheap and Ontarians are willing to sacrifice the lives of people in residences, in facilities, because they don't want to pay higher taxes. Now, if we want to create a plan, how are we going to convince Ontarians to chip in a bit more in order to support the elderly? And are we not running the risk of having a national plan that would be at the level of BC? And one thing I should say here is that my understanding of the Carolyn's proposal was that the plan would replace everything that is done so far through general revenue in the various provinces. So I was, in my mind, I was trying to think about the plan is really all we have when we need support for long-term care. And my second issue with the plan, or let's say my second concern on how to make the plan happen is that, well, obviously having such a plan would raise, we would have to have an adult discussion on the redistribution across income levels of such a plan. So the way it is described in the report for now is that we would increase the percentage point of contributions to the CPP or the QPP. And that I think is brilliant, because that in a sense, what it means is that it's flat rate. We all contribute the same as long as we earn more than the maximum average earnings, and then there is a sliding scale for people who earn less than the maximum earnings. But all this raises big issues. So it means that, for instance, people who make really tons of money, twice or three times that maximum average earnings, are going to contribute a tiny portion of their income, but they are going to receive the same as people who are close to this maximum average earnings and are then, of course, contributing a much higher share of their total income. Well, we need to have that kind of discussion, I think, and that may be more problematic than what we think in general. I would like also to, so that's why I wanted to talk about the people who never work, never contributed. In pension plan, it's relatively easy to deal with that. We give them a minimum. But when it comes to long-term care, we cannot do that. We cannot provide them a subpar in-kind type of services, or we cannot just give them a check that would be, let's say, 25% of what the other people receive. So we will have to deal with discussions of some people do not contribute, but they still receive the same, and some people contribute a flat rate, which means a much smaller portion of their income, but they still get the same and possibly even more, because we know that the richer you are, the more likely you are to survive until the age at which you need long-term care in general. And so those are my my comments. And again, I thank you, Carolyn, very much for starting that discussion. I think it's a most needed discussion. Thank you.
Thank you, Michel.
I should stop sharing.
I'd like to invite all panelists to join us on camera. And before moving to a larger discussion and a Q&A, Carolyn, was there anything from Michel or Danielle's comments that you'd like to respond to?
Thank you. I'm being told on my screen that I can't start my video because the host has stopped it. So I will just speak until I can turn. Okay, now the host is letting me start my video.
Technology.
Okay, there we are. Yes, thank you. Thank you. Thanks to both my very good colleagues for those thoughtful responses. And there's much to respond to here. I think I'll start with the political environment that Danielle was was highlighting, because it also plays into Michel's points as well. I absolutely agree with Danielle about the difficulties, the federal provincial difficulties of acquiring agreement, especially given the partisan map as it exists. But what I would emphasize is the extraordinary nature of this moment. And the fact that, as I said in my presentation, this is a focusing event. This has truly galvanized public attention to long-term care in a way that we have never seen. And it's possible, I believe, to use an extraordinary moment to forge a consensus and to establish a set of expectations for the future. Not to do everything up front, but to get a basic consensus on where we need to go and a set of expectations as to where we need to get to, and how we get there. And if there is a time to do it, it ought to be now. The reason I'm suggesting a commission or some equivalent to the commission, and we can talk about what that might be, is that it can do that. It can pursue that work of forging a consensus and establishing expectations. The original Hall Commission that established Canadian Medicare, Universal Physician Services Insurance, was, after all, appointed by a conservative government. It reported to a minority liberal government supported by the NDP. The legislation was ultimately passed with the overwhelming support of all parties in Parliament. And it was negotiated at the provinces were in compliance within a period of 5 years. So one might have looked at the 1960s partisan map and thought, this looks pretty unlikely, and I can imagine how one would. But I think the nature of this moment is something that is to be captured. So yes, Danielle, I agree. It's going to be a heavy lift, and it is not going to happen overnight. But we ought at least to be putting the wheels in motion. So more specifically on Danielle's points, should this require the same sort of amendment procedure that the CPP well, first of all, the CPP requires, and yes, I actually think so. I actually think we need to get to a level of consensus that would allow for that if this is truly going to be sustainable, and hence the importance of building that consensus and that set of public expectations. And I want to emphasize that too. I'm not just talking about expectations amongst provincial governments. I'm talking about public expectations, public concern, public expectations about what should be done. And should there be an opt-out for other provinces? I think there would have to be, frankly, and we would have to rely on public expectations as to whether the populace, the electorates of given provinces would want to see their province opt out. So let me, I guess I will now move to some of Michel's comments. The point about do we want to get to Ontario standards or do we want to get to BC standards, I think was a telling one. I think the national standards that would result as a way of approving qualifying providers would of course be minimum standards. I would hope it would be a high minimum, but it would be minimum, and certainly provinces could exceed those standards. And over time, indeed, could have demonstration effects on the diffusion of higher standards. The point about home care, I think, is an important one. It's one that comes up a lot in this context, there's a huge unmet an unmet need for home care. So even if home care did not substitute dramatically at the margin for institutionalized care, it would be still a good thing to be funding more home care. Now, the Canadian Institute for Health Information estimated a couple of years ago that 1 in 9 of each new admission to a long-term care facility could have been cared for at home. So there's a marginal substitution effect, but it's not going to be the answer to problems in institutional care. Michel made another point about the importance of separating needs assessment from provision, which I thought was a very important point. And I would draw attention here to some of the other national examples that we have, such as Japan, in which there is a care manager at the regional level. So each individual is assessed by a care manager and is directed to the appropriate facility under their long-term care insurance plan. And this would integrate a number of the assessment mechanisms that currently exist at the provincial level. There is the issue Michel also raised of the relative progressivity or regressivity of this mode of finance. And I think here we need to look at the full picture. My colleague John Miles has often reminded me that what really matters for a robust welfare state is the level of funding. And we know cross-nationally that those countries with a mix of revenue sources that don't try to rely entirely on income tax, personal income tax, for example, are the ones with robust welfare states. So look at the full level of funding that this makes possible, and the tax transfer mix as well. There are, after all, benefits associated with this. Perhaps I will leave it at that because I'd love to have more talking heads than me on the screen. So I look forward to what Danielle and Michel have to say.
So thanks, Carolyn. We're going to take some questions from the audience. The first question is about where we want our seniors to be. Can we do long-term care reform without dealing with home care? Should long-term care insurance cover all kinds of long-term care, including family caregivers?
So I responded to that in part, I think, in my comments about home care. We need more home care. It cannot solve the problems of institutional care, I would say. So should we be paying currently unpaid caregivers at home? Germany allows for this in its long-term care insurance plan. The experience has been mixed with regard to the quality of care that results. And I think we would need to be careful in moving into this space. There's a lot to be learned from Germany. You would want to ensure a similar level of care that could be provided by say, family caregivers. But that requires a lot of support and monitoring, just as we would in the paid sector. So I would be cautious. There may be incremental ways of moving so that we can assess the quality of care. But I would also look to experience in other jurisdictions as to how they've handled that issue.
I wonder if our other panelists have anything to add, Michel?
Sorry. On the first question of should we have home care and institutional care in the same bundle or in the same policy, I say definitely yes. As Carolyn said, there is unmet need for community care. I still believe that we could ease the situation in facilities with more, if we could treat more people in the community, and that's what people want to. So if we could, if let's say the financial incentives were aligned with preferences, that would be better. The question of paying informal care and trying to support informal care, it usually, well, actually Germany is doing it, Nova Scotia also. There is a small benefit in Nova Scotia for that. The main issue here is very often, well, exploitation in both directions. So you don't want some, your, let's say, poor cousin to be exploited by a greedy person who needs home care. You don't want the opposite. You don't want the greedy nephew to exploit the poor old person who does not know exactly where the money goes. So yeah, I think it raises thorny issues, but that's only also a good thing to compensate and to express gratitude for the hard work that is provided by spouses or sometimes children for dependent elderly, for sure.
So our next question, the federal government seems intent on coming up with national standards, and assuming they go ahead, what would these standards be? If the feds were putting 5 conditions on new funding in this area, what would they be, and which is the most important?
Well, that question sort of flies in the face of my recommendation, which is that the national standard should not be developed and imposed by the federal government. The federal government has no particular expertise in this area. It has a convening power. It can certainly convene those with expertise, but the whole point of my proposal here is that these standards be jointly developed on the basis of a set of data that are being generated in the course of administering a joint program. We need to go to where the expertise is here, and to the people who are going to be enforcing these standards on the ground. So I would not start at this point prescribing what national standards should be. They would have to include things like appropriate staffing plans that are sufficiently flexible to take account of local circumstances, but current regulations, for example, that require that there be a single nurse per shift, regardless of the number of beds in the facility. I mean, clearly that is a standard that needs to be rethought. But it needs to be done, as I say, on a joint basis.
I wonder if Danielle, did you have anything to add to that?
Well, I agree about federal standards. I think that we are already, from the bottom up, standards are emerging. There is, for example, the National Long-Term Care Services standards from the HSO. I mean, you have initiatives that are already taking place, and I think that it's good to have, if we can develop standards, if the provinces we can help diffuse and adopt these standards, that's great. But the idea that Ottawa will come and just, put forward 5 very broad standards and that will solve really many problems on the ground, I think that's really problematic. And politically, that's also, of course, rather controversial. If you heard François Legault about this, but also some other premiers who are not too keen on the idea, to say the least. I think Michel wants to say something about this too.
Sorry, very quickly. I think, and I totally agree with how standards should be defined. But if we are talking about the outcome, what we would like to aim for, I think what we are seeing with COVID-19 is that yeah, the staffing and hours per resident, that's important. But I think what is really important is the number of beds per room. And we've seen that when you have more than 2, that's I mean, a recipe for failure. I would argue that even 2 is strange if we think about it, because a residential care facility is not a hospital, it's a home. And it's pretty unusual in a home that you are sharing your room with some total stranger. I mean, I don't think many of us do that. So if we are serious about calling that a home, it should be, everybody should have their room. A private room should not be a luxury. Now, how we can do that, I don't know.
I wonder if I could leap in there. I absolutely agree, Michel, that the design of facilities is a huge area to be addressed. And it goes beyond the number of beds per room. It goes to the overall size of the facility and the basic layout of the facility. This is an area that needs serious attention. And I would hope that I suggested that the funding in the recent federal budget could be directed toward infrastructure. If that is not the case, I would hope that other federal infrastructure funding could be directed to this area. Both, I mean, to some extent, even retrofitting would be better than what we have, but much more broadly, rethinking the design of these facilities.
And I just want to add, accreditation is really crucial here. If you want to improve the system, you have to improve the accreditation system all across the country. And some people are working on this now, but this should be, we should accelerate this. And I think that Carolyn is right. There is a, you know, she used the term focusing event, but also the same author Kingdom talks about a policy window. And this policy window might not stay open forever. So it's the time to address these issues. But I think that unless we have to, you know, think about what these standards are, but some people have a very naive understanding of what national standards are. And you just, and I think for long-term care, working through the accreditation process and having some form of coordination among the provinces and territories bottom up, with the help of the federal government, might be a much better way to proceed than trying to impose some abstract principles that may not be that effective in changing things on the ground.
That's a great point. So our next question is about the intergenerational equity aspects of Carolyn's proposal. So won't the current working age population in effect pay twice? Once via increased payroll taxes for their future long-term care insurance, 20 to 40 years hence, and again through general revenue taxation for the subsidies needed for those who will need long-term care in the next decade or so, long before the pre-funded portion of the long-term care insurance itself matures?
So yes, this is something that I really wrestled with, but let's think about it. If we are going to meet the current fiscal challenge in long-term care, we are into a problem of intergenerational equity, however we fund it, whether it's, you know, income tax, whatever it is, whether it's general revenue or contributions, the current working generation is going to be paying for the current generation in long-term care. The advantage of this proposal is that it gets us over time to a more intergenerationally equitable solution in which the funding is over the life course. Your contributions go to fund your own care in the future, as opposed to the care of someone else in the present. So there is no way around the problem of intergenerational equity, I think. But at least this gets us in the future to a place that is more equitable in that regard.
I wonder if you have anything to add, Michel.
No, I fully agree with what Carolyn just said. This is going to be an issue no matter what. Maybe I know that the predictions on the need and the cost of long-term care in, let's say, 20 years, 30 years down the road, those predictions are usually doom and gloom. I would like to add, and I agree, overall, the doubling of the cost is certainly where we're going to go forward. A note of optimism, if you allow me, is that the gender gap in longevity is decreasing, which means that men tend to live longer, and spouses are those who provide long-term care. And I still think that we can go to more home care and staying longer in the community when husbands will be around longer to take care of their wives. And I know a husband is not great, but it's better than nothing. And so in the area of long-term care, that can help. So we are going to spend more. And one last point also on this question of intergenerational equity. I agree that some generation are going to, let's say the generations that are not large enough, and we had, let's say, we have to support their parents, are going to spend more, and that may be unfair. On the other hand, there is a trend toward living longer, and toward being, as a result, having maybe more in the age categories when you need long-term care. So the younger generation, they may pay more, but they may also benefit more from the service of long-term care than my generation, for instance. So that intergenerational equity issue is more complex than the financial flows that we are talking about.
Thank you. So we're pretty much at time. I'll give you a final moment if you'd like to add a concluding word, and thank you again for your thoughtful commentary today.
Let me just thank again all of the attendees, IRPP, and my two commentators for really invigorating discussion, and thank you for attention to this. I do hope that we can seize this window of opportunity. We need to put in place some process that will carry this forward from this window of opportunity. If it's not a commission, maybe it's a Senate committee, but we need to seize this moment to begin making progress, or the next pandemic will find us right back where we are now. But thank you very much. Thanks especially to IRPP for supporting this research.
And thank you, Carolyn, for launching the discussion. I think you have started a great discussion on the most needed discussion with a fantastic proposal, and thank you very much for that.
Yes, and thanks for the discussion. I think it's been really fascinating and great questions. We cannot answer all of them, but obviously people are really engaged, and that's a sign that this issue is still central to the agenda, and it hopefully will remain on the agenda until we can actually solve this problem to improve the well-being and the dignity of older people in this country. They deserve this.
Thanks again to our panelists for your expertise and thoughtful commentary today, and for everyone who joined us for the debate with the excellent Q&A. I'm going to hand it over to my colleague, Ricardo.
Thank you to Carolyn, Danielle, and Michel, our panelists, and to our moderator, Paisley. Thank you to all participants. Please take a few minutes to respond to our short survey. A link to it will be shared in the chat. We will also be sharing a link to register for our next long-term care webinar, which will be held on June 3rd. And the following days, you will receive a link via email to watch the webinar again and access the slides presented today. If you have any additional comments or questions following the webinar, please send them to us at communications@irpp.org. Thank you all for your participation, and stay tuned to our social channels for future IRPP webinars.